right, so today we're going to talk about something that I think is a pretty fun topic. So if you guys know me by now, I'm going to make anything applicable to internal medicine. That's what I'm applying to right now for residency. So everything that I do likely will have some internal medicine spin on it. And simultaneously right now I'm in my dermatology clinical clerkship. So about sunscreen, my dermatology clerkship. So I thought it would be, beneficial to all parties involved to have a dermatology talk, but I'm going to make it applicable to this idea of external manifestations of internal diseases. So we're going to go through some pretty cool things, I think, and really lots of things over the next hour or so. So like last time, what we're going to do is 4 cases, and then there's going to be at the end 3 slides with a lot of like rapid ones where we're just going to say, see this, think this kind of thing. So you're going to see lots over the next hour or so. Everything's very visual, as dermatology is. So some of these things are fairly rare or associated, obviously, with internal diseases, so may not come across the dermatology office, but things I think are pretty cool. So if you guys have any questions, like always, feel free to put it in the chat or yell at me, whatever works. And we will kind of go from there. I literally laughed out loud at this one. It's like it's so dumb that you can't not laugh. But I had obviously showed everybody in the office as well too. Everybody was laughing at it too. But let's start our poll for tonight. Let me launch it. So if you're new, the poll's going to pop up. Let me know how much you know about dermatology. Three people know a lot. You guys work in dermatology offices? Oh, Mohs surgery. Nice. Cool. Perfect. Well, great. Let me, I think almost everybody is in, and we have a good little gathering tonight. So let me share the results. We're kind of all over the place tonight, which is great. And I hope for those of you that do know a lot that I can teach you a little bit tonight as well. And for those of you that know a little bit or you don't know really anything at all, let's see if we can't change that a little bit and have you progress on a little bit. Okay, so let me stop sharing that and let's keep it moving so I can end on time. Last time I ended on time, which I'm very proud about, which was the first time ever. So those of you that have been here this whole time are probably like, that's 1 out of 1,000. You still have a ways to go, but a medical rat for a dermatologist in Florida. Where in Florida, Rachel? I'm in Florida. A medical rat. That is cute. You're right, Stephanie. All right. Anyway, West Palm. Okay, yeah, that's far away from me. I'm in Pensacola, which is barely Florida, but I'm here. I've made it. I'm a Floridian. Okay, so what we're going to do, as I kind of indicated before, we're going to do 4 cases. I am going to ask you guys to read them. So don't be worried about mispronouncing things. You'll mispronounce a lot of things. And if you don't know what something means, ask. Don't be afraid to ask. But I am going to ask 4 people to read. And I expect more than Stephanie to read the case. But obviously, I expect Stephanie to read one too, because she always does. And she's great. But other than that, we are going to do the 4 cases, the 3 slides with the rapid fire dermatology. You guys are going to ask questions and participate and write funny things in the chat, and fill out your SOAP note. You're going to fill that out throughout the presentation. Do it for 1 case, as we kind of have done the last 3 times I've done multiple cases. So try to fill that out for 1. And for those of you that just joined, here's the link to the SOAP note and everything else that you'll need. Okay, so you'll have access to that. Other than that, afterwards, fill out the quiz at the end. I think this is one of the easiest quizzes I've done. And for those of you that were with my presentation the last time I presented, it wasn't last week, the week before, so therefore 2 weeks ago, I did key one of them wrong. So sorry about that. If you guys were like cursing my name out there and were like, this is wrong. And the answer even said like aortic dissection, but I keyed it as I think aortic aneurysm. So if you guys were angry at me, I'm sorry. I did key it wrong and then I went back and changed it. So I double and triple checked that all of them are right this time. And this quiz is fairly easy if you pay attention. It's all about remembering visuals. So you guys will do just fine with this, I'm sure. All right, let's keep going. So here's the SOAP note form. If you guys are new, you will be filling this out. Okay, so subjective means things that the patient tells us. Okay, so those are things like the history of present illness and the ROS, so review of systems that they tell us. For these mini cases that I'm giving you, some of the information may sort of be concise, so you may not have all this information, in which case, if you want to make it up, be my guest. If you want to sort of research these things, and fill out what the patient would tell you, that's perfect to me if you want to practice your SOAP notes, okay? Other than that, for objective, that's the O in SOAP. We're going to talk about things like the vital signs and the physical exam findings, okay? And then for assessment, this is things that we find, what we think is going on. And so basically our differential diagnosis here, and then the plan is what we're going to do based off of our assessment, okay? So this is fairly simple, and we'll go through any of this. And if you guys have any questions, if you're new with us, and you have questions at the end or any time, just let me know. All right, so let me know where you guys are at. So kind of find your annotate button wherever your key or wherever your toolbar is, and pick a stamp and let me know where you're at. All over the place. Wow, it's like everybody's on a coast somewhere, except for a few people. All over. This is great. Lots of people. Everybody's catching on. You guys are getting it. All right, San Diego, great. Lots of people in oh, it looks like there's everybody from like one school there, assumably. Okay, we have in Illinois, great. Perfect. Awesome. Well, wherever you guys are at, we have a Houston, it looks like, Ontario, awesome. Lots of Californians. Oh, we have Clemson, South Carolina, awesome. There's lots of the South Carolina students here, it looks like. But thanks for coming wherever you guys are. I'm very humbled to teach you tonight. And truly, this is one of the highlights of my week. I love doing this. So let's keep it moving here. We're going to talk a little bit of derm here, and we're going to start with anatomy. Okay, so when we talk about the skin, we're really talking about different layers. Okay, so as you may or may not be familiar with, we have these main layers. We have the epidermis, and you'll see here that the epidermis is split into these different layers. Okay, and then there's the dermis. Okay, then below that we have things like the subcutaneous tissue. Okay, so but the main two things we're going to focus on tonight are the epidermis and the dermis, and you're going to find that like whether it's affecting the dermis or the epidermis really plays a role in what pathology it is, and we'll talk about some where it affects, you know, the epidermis or the dermis. But then we see that we have the these different layers here. We have the stratum corneum, the stratum lucidum, granulosum, spinosum, and then basale. Okay, and these are these different layers. They do have different functions based on them. We're not going to sort of dive too deep into that tonight, but I want you to be kind of familiar that with the fact essentially that the skin is not all one layer, like, you know, we're all made to think. And then below that, we have our friend the dermis, which it has layers of the papillary dermis and then the reticular dermis. Okay, and then in here we have things like arteries, veins, we have capillaries, we have nerves, obviously, we have hair follicles that permeate the layers, and we have sweat ducts. Okay, so let's keep going here, and I have another image as well that touches this, and this is showing you the same exact thing. Okay, it's just a different image, basically. So we have the epidermis, and they folded it all cute up here, so you can see you know, below it, and you can see the arteries and veins that are down there. And we have you know, obviously different venous and arterial nerve plexes there, and then down below we have the subcutaneous fat. All right, there's different things like we have sweat glands down there. Obviously there's the hair follicle that we talked about, and then we have like the erector muscles that affect, for instance, whenever your hair stands on end, if you're cold, or someone told you like a, you know, scary story or whatever. My spouse calls it the chilly willies. I don't know if you guys have heard that. I always thought it was really funny when I heard that for the first time, but that's what I think of when your hair stands on end, is the chilly willies. So you're welcome. You guys can take that into your everyday life. But that's what the erector muscle is doing there. It's making your hair stand up. Okay. All right. So other than that, we're going to talk a little bit about immunology here, primarily just to say that the you know, the skin is not just you know, a barrier to external things. There's also immune cells there. Arguably, some scientists call it SALT. So you'll hear like gut associated lymphoid tissue, and you'll hear MALT, mucosal associated lymphoid tissue. Here, you've guessed it, same thing, skin associated lymphoid tissue. Because what we see is all these different things, like lymphatic vessels, of which carry the lymph. Okay, we see other things like obviously melanocytes, of which affect the amount of melanin which is in the cells, and correspondingly influence the color of our skin. Okay, we also see things like T cells, CD4 cells, which are helper T cells, and other CD8 T cells. We see things like natural killer cells, and we see macrophages, which are like the trash cans of the immune cells, and then other cells that are in here. And then we see our layers again, the epidermis, which is on top, and then we see the dermis just below. And we'll see that a lot of these immune cells are really in the dermis below, because as we see up here, as we get higher up here, oops, sorry about that. As we get higher up to the top, you know, at the layers of the stratum corneum and the granulosum, we start to see the skin cells really sloughing off. So we see a lot of our immune cells, therefore, down below. All right. So here's a little bit about terminology. I always thought this was the most challenging part of dermatology, is remembering all this stuff. Okay, so we're going to go a little bit, oops, let's see. We're going to go a little bit into depth here with this. And we're going to talk about all of these different terms. Okay, there's lots of different things: macules, papules, nodules. You know, you can go cross-eyed thinking of all these things. But first, we'll start with macules. These are little flat areas on the skin, things like freckles. Okay, then papules, these are visibly raised over the skin, so these are things that you can feel. Okay, then we go, you know, one step further, and we have nodules. So those are a little bit bigger in diameter, and they're raised above the skin. Okay, and we progress down to all of these different things. Okay, we're not going to go to every single one, and then we start here is when we talk about things like that have fluid in them, like vesicles, small vesicles, when we think of things like but sometimes eczema is vesicles. They're raised with fluid, like dermatitis herpetiformis, the rash that you get with celiac disease. Other than this, we can see large blisters, like they're called bulla, and then we can see pustules, things like acne. All right, and then there's different other ones that are secondary lesions. Some of these things we're gonna talk about. We might see some scaling and crust today, really, but let me clear all this and let's keep going. All right, so we're off to the first case here after a little bit of an introduction, but let me have somebody read this first case, please.
Do we raise our hand or we just go for it?
You can go ahead.
Okay. 37-year-old female with no significant PMH presents for an annual examination. The patient denies issues with the exceptions of a 24-pound weight gain over the past 6 months. Skin examination shows the following. Number 1, a test order, and number 2, a diagnosis.
Perfect. All right, so thank you, Elizabeth, I think, right? Yes, it was, because I saw you just mute yourself.
Yeah, sorry.
Oh, no, that's fine. You
I
don't have
should
to
say my
introduce
name
yourself.
first.
No, you're fine. That's great. Thank you very much for reading that. So, all right, what we're seeing here, so we to dissect this specific case, it's going to go by fairly quickly here, but we see a young woman, no other past medical history, that has gained weight over 6 months, and 24 pounds is pretty significant. Okay, so what we're seeing on this woman is this. We're seeing some darkening of her skin in the axilla, so underneath the armpits, and the side of the neck here, okay? And we see some associated skin tags, both on the axilla and the neck. So what tests do you guys want to order? Any ideas out there? You're not wrong by ordering anything pretty broad here. This is a pretty broad thing. So a culture, we could culture it, sure. Biopsy, yeah, we could certainly biopsy. Elizabeth raised her hand. What's your idea, Elizabeth? Blood glucose? Yeah, good, Rachel.
I'll order a full CBC/metabolic.
Perfect. Yeah, I agree with Elizabeth. I think the CMP will be of value here. Somebody said blood glucose. I'm with Rachel as well. I think if we get the CMP, we'll get a blood glucose. We have to remember, is she fasting or not? If this is an outpatient clinic, we can have her fasting. But does anybody, thyroid panel? Yeah, exactly. If she's gaining weight rapidly, certainly. Because what we'll see is that with hypothyroidism, which I've taught about, and if you guys missed that, you could always go back. All the links are on that document that I just sent you. A1C, good, yeah. Fructosamine, yeah. We can definitely do an A1C. I agree with that one. And for those of you that said A1C, what does the A1C measure? We know that glucose measures the blood glucose. Yeah, good, Liz. It's a 3-month average of the blood glucose. So what it is a glycosylated hemoglobin. It shows how much sugar is stuck on the red blood cell over 90 days. Okay, so 3 months. Yeah, fructosamine, it is 2 weeks. Absolutely right. So who has ideas out there of what this is? Or any ideas of what may be going on? You can give me a broad differential because we're going to talk about it afterwards. Are we supposed to be writing anything in the subjective objective? So basically the subjective stuff is really all this stuff. Okay, so what we can say, for instance, for subjective is she has no past medical history, she denies issues, so this is all subjective here. She had a 24-pound weight gain. And then our objective is going to be this examination. And I'll tell you what it's called here in a second. So what ideas do you guys have for differentials here? And this case is going to be fairly short. So if you guys don't have information for each of these things, you could always put something brief and then, look it up later and add certain things in terms of, what would present. Diabetes, good. Yeah. So what if I told you that her A1C was, let's say 9. Is this good or bad? Very bad, yeah. A normal is less than 5.6. And then diabetes is greater than 6.5. So she certainly meets that qualification. Okay, and let's say her blood glucose was 300. Good or bad? Anybody? Very bad, yes. It's almost a rhetorical question, is that bad? Somebody put V bad, and I love that. That's what I say all the time. And people remind me I don't have to abbreviate very, but I feel like it's necessary. So good. Somebody out there said what this is, and I think you guys are on the right track. We're looking at some sort of metabolic syndrome here. And what this is called is acanthosis nigricans. Some very smart person out there had told us what this is. That's what this is called. And acanthosis nigricans, what it is hyperpigmentation. So we're seeing that here. We're seeing, this darkening of the skin, and hyperkeratosis. So what we're seeing is the epidermal hyperplasia. We're seeing increased quantities of the epidermal layer. Remember our friend, the epidermis on top and then the dermal layer below? We're seeing increased cells, increased growth of that epidermal layer. Okay, so that's why we're seeing this darkening of the skin. And commonly we see it in areas like the neck, the axilla, and sometimes the groin as well, but it's most common on the neck and the axilla. Those are usually the areas that we see. Sometimes the patients aren't even aware this is going on because it's on the posterior neck, often we'll see. So we'll say, how long has this been going on? They won't even know it's there, okay?
Interesting question.
Okay, my watch wanted to talk to me. I literally hate when that happens. So Siri was screaming at me. So what we see this associated with is things like insulin resistance. Okay, so metabolic syndrome. So things like obesity, diabetes, PCOS, and Cushing's syndrome. And then we also see it rarely associated with malignancy, and this is specifically gastric adenocarcinoma. Okay, and to treat this, we treat the underlying cause. And this isn't to say that the acanthosis nigricans will go away when we treat the diabetes. It could be there permanently, but this is something, in a lot of these skin manifestations are treated by treating the underlying cause. Okay, and so what we were looking at for this patient was primarily diabetes. Okay, she had a high A1C, she had a high glucose, gained lots of weight over time, but due to her weight gain, we might be concerned about something like Cushing's syndrome, where we have a problem with steroid hormones in the body, and the the adrenal pituitary axis. Okay, so those are things we want to consider when we see acanthosis nigricans. Okay, so this was a fairly quick case. If there's any questions, feel free to shout them out. But our case really focused on this idea of diabetes, and that's really the most common that you're going to see in the United States, and where we have kind of this obesity epidemic. All right, great. So let's keep going here, and if you guys have any questions, feel free to ask. Now let's get a new reader for this one. Lots of shy people. Feel free to read. Is there a separate soap note for each case? No, great question. So just choose one of the cases and fill it out for the one case. And then if you finish, then you can kick your feet up and just enjoy the rest of the presentation. Okay. And as I was kind of mentioning, if all of the information isn't actually in the case, look up the pathology, or based off of what I taught you about the pathology, feel free to plug it in, but use the information that was presented to fill out those things. I understand if it's brief, a lot of these cases are brief based on, what I usually teach in one extensive case. Okay. All right. Who wants to read?
I'll go, and I'll go on a camera today because I can. My makeup looks fantastic. I was presenting today. So, okay. So a 24-year-old female presents with a 2-month history of intermittent facial rash. She also noticed occasional diffuse joint pain. I don't know how to pronounce it. Arthritis. Sorry. And thank you. And overwhelming fatigue. Family history is unremarkable, including for autoimmune ailments.
Awesome. So arthralgias is that word. It's like the counterpart for myalgias. Myalgias meaning meaning muscle, so muscle aches. Arthralgias is joint aches. Okay, so that's just joint pain. What tests are necessary here for this patient? So similar to last time, what tests do we want to consider here? Where can I see this? So, oh, here you go. There's the, so CMP, good. So we can certainly get blood and urine. Yeah, we can. What do we want to test for in the blood? ANA, good. Yeah, we can certainly test for an ANA. Good, I agree with you. Her ANA is positive. Now what? What else? There you go. You have a positive ANA. For you guys that said you wanted an ANA. Now what? What do? You're the doctors. Room panel, good. Yeah, we can definitely get a room panel. What do we want to test in the room panel? What are we looking for? Because we see this picture over here, we see this rash that's on her cheeks, not sparing the nasolabial folds. So that tells us something. Rachel is thinking lupus. I'm thinking lupus too. Good. Not because I wrote this case, but because she has a butterfly rash. Good. Anybody else? Any other tests we want to get here? Yeah, we can see if her white cells are elevated, especially because if we get a CBC and it's elevated, it could tell us that there's inflammation. Good. What differentials do we want to consider here? Other than lupus? So we want to think about autoimmune things, obviously, but what else? We obviously have, good, lupus, rosacea, good. Yeah, we can consider rosacea, absolutely. We see it on the cheeks. We see those telangiectasias. It's, called acne rosacea. We can think of things like eczema. We can think about things like psoriasis. Good job. You guys are on the right track for this one, I think. So good. We had a good differential here, and Rachel was right. This is lupus. So she had the butterfly rash, but remember, and I was just talking to a dermatologist today who said, out of the 10 years she had worked in dermatology, had only seen the we call this the malar rash, the butterfly rash here, had only seen that twice in 10 years. So it's not as common as we think, where we think butterfly rash, think lupus, but it is pretty characteristic. Okay. Another time we can see a rash on the face is a condition called dermatomyositis, and remember that might come up later in the presentation, where we see this rash. That one's called a heliotrope rash, and that's a myositis, meaning inflammation of the muscle cells. But what we see in lupus is this autoimmune complex disease. So we see deposition of antigen antibody complexes in the tissues, which causes an immune response. Okay. So this kind of perfect storm that we get with autoimmune things is we see number one, that the patient has the genes for it, okay? So we see all of these different things play a role. So different HLA genes, HLA D2, 3, and 8, but we also see things like complex playing a role, or complement, I'm sorry. Other than this, we see, you know, different interleukins, IL-10 playing a role in different genes in general, okay, different parts of the immune system. All right, and then we see an abnormal immune response. So we see these dendritic cells and T cells and B cells all having an immune response to these immune complexes, antigen antibody complexes. So here's the complex, here's the antigen antibody complexes, and we're getting autoantibodies to them, okay? And then what we're seeing is this idea of inflammation. So yes, we can get inflammation on the face like this picture suggests, but we can also get it in the way of the kidney, and that's what's bad. We see lupus nephritis, and then we see other complications like hypercoagulability. We can see, you know, problems with the heart. We can see CNS disorders, different things like that. So it's not just, you know, skin manifestations, you know, as this presentation would suggest, we see external manifestations of internal diseases, okay? So we can see other things like serositis, so we can see pleuritis and carditis, as I just indicated. We can see problems with coagulation. We can see problems with the white blood cells. So we can see, you know, yes, the white blood cells can be up if there is inflammation, but we also sometimes see them very low. So we see cytopenias. We can see thrombocytopenia, so low platelets. We can see leukocytopenia, so low white blood cells. We can see a pancytopenia where multiple things are low, okay? We could see lupus nephritis, and we see that double-stranded DNA, the test for it. You guys said room panel, you all cheated, and we're like, okay, we're going to send it all to the lab, and the lab's going to tell us what's positive. But really, these are the things that we want to look out for on the room panel. Okay, so we see that double-stranded DNA is positive for lupus nephritis, and then we can also see neurologic disorders. Okay, and see, you know, fatigue, confusion, hypercoagulability, and strokes. ANA, that's what you guys mentioned. This is kind of this gateway antibody here. And what we see is that it's sensitive, meaning if it's positive, it tells us there's something rheumatologic going on or autoimmune going on, but it's not specific, okay? If an ANA is positive, it tells us there is something going on, but it doesn't tell us, you know, what it is or where it is, okay? The same way the D-dimer test tells you there could be, you know, fibrin split products somewhere in the body, but doesn't tell us where, okay? It's very akin to that. We can also see anti-Smith antibodies. Those are actually specific for lupus, okay? Other than this, we treat this with hydroxychloroquine, and you'll see the picture here. This is what we call discoid lupus, and often we'll see this. And if we see this on the skin, what we'll do is we'll numb it up with lidocaine, often with epinephrine to vasoconstrict the blood vessels, and we'll take a biopsy, a shave biopsy usually, and we'll send it to pathology, and pathology will stain it and look at it under the microscope and tell us what's going on. All right. So that's a quick one about lupus. So we still have a couple cases to go and lots of rapid fire. So we seem to be doing okay on time so far. All right, case 3. Let me get one more reader here.
I can go ahead. My name is Sarah.
Awesome, Sarah. Thank you.
All right, no problem. A 21-year-old college student presents to student health with a complaint of painful bumps on the interior shins for 2 weeks. The patient denies other symptoms, including fatigue, SOB, sore throat, cough, NVD or HA. No PMH or medications. She notes she just returned home from break and her brother had a sore throat. Tests to order.
Awesome. Thank you very much. So a few things here. This is shortness of breath. And then the N/V/D means nausea, vomiting, or diarrhea. And then the HA is an abbreviation for headache. So if you ever see these things when you're, volunteering or shadowing, that's what all this means. And PMH means past medical history, okay? So those are a few abbreviations that you may not have been familiar with. But what we see on examination, we look at her anterior shin. So this is her knee here, and we see her ankles down here, obviously. But we see, what she would say is right. It looks like bumps, and she's telling us that they're painful. They're not itchy. We see that when we palpate them, they're kind of raised lesions. She kind of wants to kick you in the head because they hurt and you're pushing on them. So we believe they're certainly painful to her. Okay. So what tests do we need to order, guys? What do you think? This is a tough one, and I included it because I have seen this in real life. I saw it on my family medicine rotation. So think broadly. I'm open to anything because, we had to also think broadly when we saw this. Okay. So what do you guys want to order? You're in charge. So some things I want to look at. Yeah, so good. CBC. Good. Perfect. CBC. Anything you want to look for specifically on the CBC? ELISA. What are you looking for on the ELISA? So one thing that I've learned personally is, and your attendings are going to say this too, when you get into medical school, is you have to have a reason why you're ordering things. Okay. You can't just press enter and order it despite the temptation. You have to have a reason why behind. So good idea for the Lyme. We'll see Lyme later as well, and it'll be very characteristic. So CBC, what are you guys looking for on the CBC? And there's a couple things for imaging that I want you guys to consider, and you may not think of it. But what do you want to look at for imaging if you were to order anything? But I do want to get a CBC. You guys are right. Because what this looks like to me is inflammation, right? Yeah, look at the neutrophils specifically. Because if we see an elevated neutrophils, greater than 10% bands, we call that a bandemia. We call that a left shift. And we know that there's some inflammation or infection going on in the body. Good. What imaging do you guys want to order? It's a hard one, I know. Any ideas? Ultrasound? Yeah, the ultrasound is a great guess, and you guys probably aren't going to guess what I'm going to tell you I want to order. What I want to order is a chest X-ray. Does anybody know why? Strep. Good job, Rachel. That's exactly what I want to order also. I didn't think you guys were going to get that, and I'm very impressed. We want to order a strep too. Good. Does anybody know why the chest X-ray? Is a shortness of breath? Good. Yeah, we do want to evaluate, or she has no shortness of breath, though. She denies the shortness of breath. Oh, good job, Rachel. So her brother had a sore throat, so I was wondering if it was strep. Yeah, I mean, that's very intuitive. I almost didn't put the brother with the strep in there, but I was like, I got to throw them a bone here. I can't give them all these ambiguities and expect them to get it. So good job. The strep, certainly, I want to order. And the chest X-ray, I'm going to show you in the next slide. So good job, guys. You guys are paying attention, I see. All right. So contact dermatitis, yeah, bilateral, good. And I should have gave you guys a opportunity to do your differentials there, but I got too excited and I jumped in. So this is called erythema nodosum, okay? So it's these painful raised lesions on the anterior shins, okay? You can see this, you will see this. I saw it in my family medicine rotation as an outpatient. So what we see, you remember that subcutaneous fat I showed you, a billion slides ago now? when we were just getting warmed up. We had the epidermis, we had the dermis, and then we had the subcutaneous fat. What we're seeing is inflammation of that. We call that a paniculitis. Okay, so that's what's going on here. Okay, and you guys asking for the CBC, great job. Rachel, who asked for the strep, great job. This is associated with strep throat. Okay. Other than that, if I see erythema nodosum in my head, I know it's associated with tuberculosis and sarcoidosis, as well as coccidiomycosis and histoplasmosis. And you guys probably all went cross-eyed and you're like, what are all these things? Those are all pulmonary diseases. You guys probably are familiar with tuberculosis. Sarcoidosis is an autoimmune process going on in the lungs. Here's the chest x-ray of it here. And then we see fungal infections of the lungs here, coccidio, that's found in the desert, mainly New Mexico, Arizona area, sometimes in Southern California as well. I know some of you guys are from California. You might be familiar with coccidiomycosis. And then histoplasmosis is usually found in the Mississippi River Valley. These are all fungal infections. Sarcoidosis, we sort of see this inflammatory immune process in the lungs, and we see bilateral hilar adenopathy. So you'll see this, what these arrows are pointing to here, kind of these, fluffy hilar adenopathy. So inflamed lymph nodes in the hilar region of the chest x-ray. All right. And so, this is associated with strep throat, and that's why I added this case like this. And the case that I saw was, as I indicated, in my family medicine rotation, young girl, as I kind of indicated, and came in just with this, rash, these bumps on her leg. Was like, nothing's going on with me. I feel fine. She didn't have a brother who had that. I just added that in because I wanted to give you a little bit of clues here, but was completely normal other than these bumps. So the workup and what the emergency department had did was order a chest x-ray. They saw erythema nodosum and they said, does she have sarcoidosis? She's young, otherwise healthy, could have sarcoidosis. And the chest x-ray was completely normal. Okay. And then it kept getting worse. Rachel must have been working at the clinic and said to order a strep throat, swab, and we did, and then it was positive. She had no strep throat, she had no sore throat rather. The strep was positive though, so positive for strep. So we treated the strep throat with usually penicillin or amoxicillin. Treated that, and the erythema nodosum went away. So tell her to get a tonsillectomy, easy fix. I can attest to that. I had my it sounds like not an easy fix though, Rachel, because that was the worst surgery I've ever had. It was a tonsillectomy. I didn't talk for like a whole month, and my family was so grateful that I had it because I didn't talk for a long time. So they were grateful. I wasn't. Still the hardest surgery I've ever had. Yeah, if you had it when you were a baby, you don't even remember. I was like 8, and I was bribed with ice cream and I still didn't want to eat it. But, this did happen. This was the exact case that I saw. So I wanted to point it out. Pretty cool case, I thought. But let's keep going. This is our last case, and then we're going to have some rapid bribed with being able to breathe at night. That'll bribe you. All right, so let's get one more person to read this one, and then we're going to do some rapid fire at the end, which is pretty fun. Anybody out there? Anybody?
I can read again if nobody wants to in like 20 seconds, but
Elizabeth is the GOAT. She's the greatest of all time. Unless somebody, oh yes, great.
Okay, a 35-year-old female presents with a weird rash on her lower extremities for the past 3 months. She knows that the symptoms are most prominent in the extremes of temperature. No, okay. Pruritus or pain associated with the rash. She also noticed cold hands and numbness when at her son's football game in November.
Awesome. So there was no abbreviations. You got an easy one. So, and you said pruritus, right? So you did well.
I'm a
Awesome.
dermatologist already.
Exactly. Yes. There you go. All you need is the board scores, and it's a very competitive field. All right. So what we see over here is this. We see this rash that she says, she's like, this looks weird. I kind of have it on my lower extremities, which I have a story because I literally saw this today in clinic, and a dermatologist and I were talking about it, and we looked at each other like, maybe we were just talking about this. And it's not that common to see really, but and we'll see the associations with it, and we'll kind of talk about that later too. But we see your hands are blue, which is not good. And then here's the picture here, and her hands are white, also not good. So what are you guys thinking? What do we want to order, or what do we want to? Oh, she has an idea. Okay, what's your idea, Rachel? And anybody else, if you have ideas, throw them out there. I'm open to suggestions. All right, anybody out there? So she's getting cold hands. So yeah, you can think Raynaud's, which is great. So we can order, remember, we just talked about it. What do we order to see if it's an immune condition? We can see liver function, great. Why do you want to test liver function, Elizabeth? I think Elizabeth is already in medical school. She's very smart.
The discoloration on the fingers.
Okay. And what do you guys want to order for Raynaud's? Knowing that Raynaud's is an autoimmune manifestation, we just talked about this. What do we want to order if we're ruling in or out autoimmune things? Yay, A&A, great job. Vascular problems, certainly we can think about that, especially in the small capillaries of the hands. Good, perfect. You guys are all on point with the A&A. You guys are paying attention, I see. Excellent. What else? So somebody mentioned liver, which I think you're right, but I think you're right for a slightly other reason than I would say. Autoimmune, perfect. Okay, any other tests you guys want to order? Check the fingernails, yeah, see if they blanch, certainly, yeah. So when we say they blanch, you push them and then they go white and then they turn back red. Not really a test. So that's an exam. I'll take it. Anybody else? What else? I think you're on point with Raynaud's. But then you're gonna be like, oh, Emma, because I led you up that path, but it's not that. So let's talk about, yeah, we could do an ultrasound. Yeah, you can do an echo for the heart too. Sure, I think you guys are all right. So here's, you guys got a CBC, and here's what the differential, the microscopic showed. What are you guys thinking now? Her hands are getting cold in the winter-ish. I guess it's fall, depending on where you are. Unless you're in the East Coast, like half of you guys, and then I heard it's already like 40 degrees, so it's certainly winter according to my standards. So you see this clumping on the blood slide of the red blood cells, 70. Where are you at, Rachel? Yeah, exactly. My good friend just went back to the East Coast and said it was 45 degrees. Oh, 70. Yeah, I think it was like cold here, like 50, but you guys see clumping on the blood cells. Yeah, we can get a PT, PTT, certainly. But what about if we see clumping here? It's, you know, cold. She's getting cold hands and white. Yeah, you guys are thinking Raynaud's. All right, here, I'll tell you. What we see, that rash that we saw, or that dermatologic manifestation that we saw, this is called livedo reticularis. Challenge your friends to say that 5 times fast. And what this is, and what we saw here, is a dermatologic manifestation of something called cold agglutinin disease. So we saw autoimmune hemolytic anemia, and this is cold agglutinins, okay? So what we see, and we're focusing here on this blue one, it's so appropriately colored, is this IgM antibody. It's this perfect storm that we talk about. They have IgM antibodies. You get the optimal temperature, so a pretty cold temperature, less than 30 degrees Celsius. And then we see that the IgM antibody, this antibody that I pointed out here, this pentamer here, reacts with the polysaccharides on the red blood cell, okay? So we see those agglutinins, and this cartoon looks almost identical to what we saw in the actual slide, okay? And then, you know, its counterpart is warm autoimmune hemolytic anemia is the same thing, except for we get this IgG antibody. So this classic antibody here. And then we see in warm temperatures, the IgG antibody reacts with the red blood cells. And what we see is it picks off little parts of the red blood cells, and we get something, instead of this biconcave shape like we see here, we get these spherocytes. And that causes a problem for the spleen primarily, okay? So I know you guys were all thinking autoimmune, or you guys weren't thinking that actually, sorry. You guys were all thinking Raynaud's, and it is almost identical to Raynaud's, and that's okay. You guys were thinking the right thing. And in your differential, if someone has cold hands, you're not going to say, oh, livedo reticularis, this is obviously cold agglutinin. You're going to work up lots of things, because as you've kind of seen, these dermatologic manifestations are associated with multiple things, not just one thing. So you're going to have lots of things to work up. And the other thing, and I actually saw it today, is it's associated with hepatitis. We saw a patient today of whom had hepatitis and also had livedo reticularis. And we were like, wow, we were just literally talking about that. Sometimes cool when things, you know, you study things and then you're like, wow, I'm seeing things, and then you remember them, okay? And then otherwise they're associated with thrombosis, like protein CNS deficiency, which causes hypercoagulation because you can't break down the clots, disseminated intravascular coagulation, DIC, and then antithrombin 3 deficiency, all right? And what we see is this reticular lacy discoloration of the skin. It's pretty characteristic, you won't miss it. And then when we talk about autoimmune hemolytic anemia, as we just talked about, there's 2 different types, warm and cold. And we diagnose it by the direct or indirect Coombs test. And there's different treatments based on, you know, the different types. Warm is, you should have known we needed a Coombs test. Oh yeah, Riley, you should have known. But other than that, you know, for warm, we treat it with steroids, a splenectomy, because remember the spherocytes cause problems for the spleen, and immunosuppressants, things like rituximab. And then for cold, we avoid triggers. So we tell them, you know, don't live in Boston. Also wear 77 layers of clothes and your wool mittens. And, you know, sometimes we can do an exchange transfusion to get the bad antibodies out of the blood, out of the plasma, that is. And then we can also do immunosuppressants like rituximab, a monoclonal antibody. Remember, anytime you see anything MAB, that is a literally an abbreviation for monoclonal antibody, okay? So that's just a little cheat there. All right, so there's the picture of livedo reticularis. Okay, you may or may not see that in your quiz. You may or may not see a lot of things that I've shown you on the quiz as well. So remember these pictures. Okay, so this is my, I'm developing a monoclonal antibody. Ooh, yay. So we're gonna do some rapid fire things here. So I'm going to show you a picture. I want you guys to type what you think it is associated with or what it is into the chat, okay? Just throw anything out there. We're gonna do these things pretty quick. We have a few minutes to go through all these things. They're gonna be pretty rapid, okay? So here's the first one. gross. And I've shown you this exact image, and I hope that one of you out there that has watched my presentations remembers what this is associated with. I'll be very proud and I'll cry with happiness. Anybody? Has to do with the gastrointestinal tract. All right, I'll tell you, unless you guys are slow typers. Oh, close. Oh, Crohn's. Who said Crohn's? I'm very proud. Did you come to my presentation? She did. I know. I remembered your name, Ashley. You did. I think you came. It's irritable bowel disease. You're very close, Stephanie. It just looks very infected. Yeah, it does. It absolutely does. This is pyoderma gangrenosum, and it's associated with autoimmune things like ulcerative colitis, Crohn's disease, and arthritis. So great job. All right, what's this, guys? So say you have a patient, this is on her her elbow, and she, every time she eats a deep dish pizza, she gets diarrhea. Yeah, good job. It's celiac disease. Perfect. Gluten intolerance. In other words, gluten intolerance, right? So this is called dermatitis herpetiformis. The thing that we call, or why we call it herpetiformis, is the lesions, those pustules, look herpetic in nature. Okay, so it's herpetiformis. Some things are just named just right. Oh, you have celiac disease, represent. Yeah, you can't eat a deep dish, I guess. You have to go for the gluten-free, which arguably I think sometimes are better, but I don't know. That's we can do a poll on another date for if gluten free pizza is better or not. But yeah, usually we see the dermatitis herpetiformis, initially maybe, or I like cauliflower crust too. We can see that dermatitis herpetiformis whenever it pops up for diagnosis. May or may not see it. Not everybody with celiac disease has dermatitis herpetiformis. But that's just a association there. Okay. All right, next one. We talked about this last week, or not last week, 2 weeks ago. Whenever I talked about vascular things, everybody that was there, make me proud. I know you guys know what this is. Close, Liz, close. Think of the venous side. Yeah, good. It's stasis dermatitis. And what it's associated with this venous insufficiency. Yeah, good. Stasis derm. Yeah, good job, Matthew. I knew you were typing that. I was going to say Matthew was there. All right, so we have one more over here. What's this? Somebody, please, out there who I told you you'll see it later. I know you guys know this. I've taught it in the infectious disease block. Remember? Good. It's Lyme. You guys got it. Perfect. Perfect. Way to go. We see that target rash. It can look like ringworm. You'll see ringworm later on. Hint. But good job. This is ringworm, or I'm sorry. Oh, you guys are confusing me now. This is erythema multiforme. It's associated with Lyme disease. Okay. Good. All right, here comes some more. We have 2 more slides of rapid fire ones. What is this? This is a hard one. It looks like impetigo, certainly, and actually that's what the dermatologist I was speaking with today said, and it absolutely looks like it. It's the rash is called necrolytic migratory erythema. So whenever you guys want to sound smart, when you're at your social hour or you're at your dinner parties, you can say that you know this rash and that it's associated with a glucagonoma. So glucagonoma is a tumor of the alpha cells of the pancreas. And that was that some dog's ears I heard in the background. Yes, it was dog ears. Good call, because my dog likes to be abrasive whenever I'm doing things that are important. Needless to say, they're always locked away when I'm doing interviews and things. But yes, they're in the background. They get restless. They're like, yeah, time's up. But this is a a glucagonoma. It's associated with a glucagonoma. It's a pretty specific rash. It does look like impetigo, as Riley had indicated. All right, let's keep going. What's this, guys? It's a hard one, I know. This will be on your quiz. When anybody says something like that, you guys start paying attention. Oh yeah, there's seborrheic keratoses. Oh yeah, Riley works in dermatology, so she knows all these things. Yeah, there's seborrheic keratoses. We call them SKs. Some people call them barnacles. That's what I learned in my dermatology. I never heard of that until I started dermatology. All right, so these are seborrheic keratoses. Do you guys know what it's called when a sudden onset of multiple seborrheic keratoses, rapidly come on? Do you know it, Riley? Sorry to call you out. You work in derm. Okay, it's called the lesser Trelot sign. So if these onset rapidly, it can be associated with gastric adenocarcinoma. So Riley, you can go back to your derm clinic and say that you learned something about derm. So I expect you to say, you know, even more in the poll. All right, so yeah, you can impress the dermatologist and say, you know, the lesser Trelot sign, but it's usually that there's a caveat. This is like a sudden onset of multiple of these, usually in a young person. You know, a lot of older people just have a lot of seborrheic keratoses on their back in general, due to like sun damage, sun exposure, stuff like that. All right, so you have this woman, she has parotid swelling. And you tell her, open your mouth and say, ah, and she shows you this. What is this, guys? Do you know this? Dry parotid swelling. We call dry mouth xerostomia. It's another autoimmune condition. All right, this is parotid enlargement and xerostomia associated with Sjogren's. So it's an autoimmune condition affecting the parotid gland, sometimes the submandibular gland. All right. Here's another one. So this is associated with a lot of things. It's multiple things. So what we see, there's a mnemonic for it. Conjunctivitis, that's a C. Redness. So we see pulmonary erythema. A, adenopathy. S for strawberry tongue. And H, I forgot what the H is. Something for the H, but now I'm forgetting what it is. Oh, hand erythema. So that's the mnemonic. And then we say crash and burn, so fever. And this is all in a kid, okay? I know you guys don't know this one, so I'll just tell you, it's called Kawasaki's disease. And the problem with this, and this is the only thing that's treated with aspirin, because we don't like to give aspirin to children because it can cause Rye syndrome, but we give it in Kawasaki's disease to prevent, the complications like cardiac aneurysms and small children. So that's Kawasaki disease. I have one more slide for you, and then I won't take up any more of your time other than to ask you the poll question and to stay around if you guys have any questions at the end. Okay. So somebody said it out there. What's this? You guys know this one. A wrestler, a small child who plays baseball and wears, yeah, good job, you guys got it, ringworm. We call it tinea corporus. Tinea is the fungus, okay? If we see it on the groin, we call that tinea cruris. If we see it on the body, we call it tinea corporus. Okay, so this is ringworm. What's this? Do you guys know this one? Ooh, you've had ringworm. That does sound like it sucks. I haven't had it, but I can certainly imagine. All right, so you guys know what this one is called? These little never play in sandboxes. That's the lesson. If you guys learn anything from today, it's not to play in sandboxes. So what are these? Do you guys know? It's so we see raised lesions with the central umbilication. So that's sort of central dimple there. That's a virus. So this one is a molluscum. Oh, chancre. That's close. Chancre's more on the genitals. Shingles. Oh, pox virus. Nice. So yeah, it is a pox virus. I don't know if you wrote that after I put the answer up, but I'll take you for your word and say that you didn't do that. And this is called molluscum contagiosum. It's a pox virus. So in kids, it's, you know, fairly normal. And you know, in fact, I saw it this week on, I got really excited for this one because I like wrote this presentation on Monday, I think. And then like over the week, I started to see these things, probably because I wrote about them, and then they started popping up. I saw this literally on, I think Monday or Tuesday, and it's common in kids. In adults, it's an AIDS-defining illness. We don't really see it in adults. So if we see something like that in adult, we start to wonder why they're getting it, okay? An opportunistic infection, you got it, Riley, exactly. Okay, so what about this? Do you guys know what this sign is called? It's on the breast. Can SOAP link be emailed with recording? Yes. So, and here's the document with all the stuff in it. What did you guys say here? Looks like breath. Yeah, good job, Stephanie. You got it. I'm very excited. That I get very excited for you guys when you get this. You guys all make me proud. So yes, this is time for breast cancer. It's called peau d'orange. So I think it's French for orange peel, but I don't know. If you guys actually know French, correct me if I'm wrong. I could be completely wrong, but that's what I thought. Sounds French. And here it is. It's you know, a sign for inflammatory breast cancer. And when you look at this, you know, it kind of looks like an orange peel. Okay, so let me clear all this, and we'll keep going here. And here's the last one. And I told you about this condition when we talked about the malar rash of the face. Do you guys remember what that's called? So we see a few things. We see the shawl sign here over the back, like an actual shawl. We see a heliotrope rash around the eyes. So that's what we see kind of here and here. And then we see Gottrin's papules, these kind of redness over the knuckles, okay? I told you this wasn't, you know, sometimes we see a rash around the eyes with this condition as well. Yeah, dermatomyositis. I'm not sure if you knew that or you remembered that, but you have a great memory. Great job. It is dermatomyositis. And what we see is inflammation of, the muscles, okay? Shawl sign, that's exactly it. Yeah, and we see the shawl, it's like a woman wearing a shawl, if you can imagine that. Some things are named appropriately in medicine, which makes our lives easier. And that's exactly what we're seeing here is the shawl sign. All right, guys, so that's the last one I had for you for the rapid fire. I took 10 minutes over my time, which is more of my status quo, but let me give you guys the post poll here and take up a couple more seconds of your time. I'm going to relaunch it here. So fill that in for me, if you will. Just let me know what you guys think in terms of if you learned anything, what your thoughts are. And then as always, I'm very, very humbled to teach you all. I love doing this. I love that a lot. A few more people came out than usual. It's always the highlight of my week, really. And what I'm going to do is I'm going to show you the results of this, and then I'm going to stay around. If you guys have any questions about anything, applying to medical school, this presentation, if you need good show suggestions or book suggestions or anything, just let me know. I will be back in 2 weeks, I believe. My colleague will be back next week. And then I will be back in 2 weeks, I believe. And let me know if you guys have suggestions of what you want to hear about, put it in the chat. I'd be happy to talk about anything. And if this is your first time, go back and watch all of our old ones. You can find some of my old presentations there where I said I talked about this here. You can go back and watch it and watch my old jokes. Maybe they're still funny. I don't know. Let me share the results. So I'm very humble. None of you guys said you know nothing. You guys said you know a little, you know some, and a few of you said you know a lot now, which is great. So what I'm gonna do is I'll stay around for a little while. And if you guys have any questions at all, feel free to ask. Otherwise, you can leave if you want. Or you can stick around, whatever works for you guys. But I'll be back in a couple of weeks. And have a great night, everybody.
Hey, Emma, so I do have a question. Can we go back to the Kawasaki disease
Yeah.
slide?
Oh no, that's what I get for adding animations. Takes forever to get that.
Oh, I totally get it. Okay, so, God, okay. It's spooky season. So I was looking at the cardiac aneurysm. Are we looking at the ventricle or are we looking at a zombie owl?
Yeah, that's what I thought too when I first saw it, and I was like, okay, yeah, we're looking at the aneurysms like up here in this portion of it. Not yeah, and I saw an owl too when I looked at it because I was like, what is that actually showing? And then I looked at the text and it was like aneurysms, and I was like, that wouldn't have been my first impression, but yeah, it's showing you some cardiac aneurysms there.
Okay, because like that was literally my reaction. I like did a double take. So then
it's not the best picture of it, but you can probably Google Kawasaki's disease and find some better aneurysms. But yeah, that's what they put. I thought it was a good kind of showing everything, and it happened to include that. But
okay, great. Yeah, I was just kind of curious if like the aneurysms, like is if this particular owl zombie thing was like kind of the general manifestation, but it sounds like kind of not necessarily. So okay, I was just curious about that.
No, we're preventing that complication. Not everybody with Kawasaki disease gets cardiac aneurysms, and what we worry about with children getting COVID is this infection that we that is called MIS-C, MIS-C. MIS-C, and what we see is almost this similar manifestation to Kawasaki disease, which is cardiac aneurysm. So it's causing a similar manifestation. So that's what we worry about with this is getting these aneurysms, which is not reversible. So we want to treat it rapidly with steroids and aspirin. Okay.
Well, thank you.
Absolutely. Happy to help. Any other questions, guys?
Hi, I have a question not related to the to the presentation, but more.
Okay.
This is my first time here and this is like really good. I actually have known about this for a while, but I didn't have the time to do it, but I'm happy that I started now. And I just wondering if you have any advice on medical school applications. I'm actually applying next year.
Okay.
So yeah.
Yeah, great. So my advice for you is a few things. First, it's a long process, yes, and it can be, you know, stressful in terms of getting kind of all your ducks in a row. And what I mean by that is the application itself. Take it seriously and start early, okay? Now, you know, if you're applying, you know, to apply in May when the application cycle opens, my first piece of advice is start your personal statement now. You have nothing to lose, okay? Get your story out there and thoughts on paper in terms of why you want to be a doctor, okay? That is what I think is often the hardest for students, is this writing element. Okay, and I would be happy to work with you guys if you're still out there and want help with your writing. I love writing, so I'm an exception. I think a lot of people in medicine don't like writing. But get your thoughts out there and start, writing down your personal statement, writing down your activities, all of these things. And then my second piece of advice is apply early. Okay. The application cycle varies from year to year when it opens and when you can submit, but usually it's around May, June timeframe. If you submit it within the first 1 to 2 weeks when it opens for submission, I think that's great. You don't want to, if you're a reapplicant, that's okay. And I was a reapplicant too. It took me 2 times to get into medical school. So, you definitely want to emphasize on your second time around what you've done to kind of beef up your application. How many shadowing hours do you need? In terms of shadowing hours, there's no like set hours. I see variations of everything. I've seen anywhere from hundreds of hours to a few hours. I think at a certain point, what matters is quality over quantity, but having, more hours is obviously better. So, you don't want to have lots of hours, to compromise your success in medical school, or I'm sorry, in undergrad right now. But there's no set number that I have in my head. You'll probably read set numbers out there. I think if you have a cause that you're dedicated to in terms of volunteering regularly, the hours will come easy, something that you enjoy doing. Okay. So no set number, but those are the 2 pieces of advice I have for you, kind of the long and short. Elizabeth, we do have advising too at Motivate MD. So if you want to set up an advising session, always reach out to Becca and we can, talk extensively too, or anybody else that's on here that wants to do advising. I would be happy to. I'm an applicant for Match this year, need shadowing. So like the residency match. Or like Match for Texas. And if you guys need shadowing, always good opportunities are free clinics. Often you can get lots of hands-on experience and taking patient histories and stuff like that. Nice. Residency. Good. Me too. I'm applying right now for internal medicine. I don't know what you're applying for, but yeah. Any other questions out there?
I don't have a question regarding the sessions or anything, but I do want to offer a shout out to you, Emma, because you once again inspired me to do something at work.
What did I inspire?
So I remember when I first started these virtual rounds, kind of every once in a while when I know you and Becca were working out kind of like the technical stuff before session started, you would kind of put icebreaker questions in the chat. So I decided to develop a whole kind of like section in my presentations to just do a whole bunch of icebreaker questions. Today's was is a hot dog, a sandwich, and that started a whole riot, and it was awesome, particularly because today's presentation was training our community health workers about vaccine boosters and additional shots and stuff like that. So like I try to kind of keep a sort of boring topic for the general public a little more interesting, so that was really fun. So if you ever need like more icebreaker questions, I thought of a couple and I'd be happy to send some over.
Yeah, for sure. I would have done one today, but I was a little late to the party because I was making espresso, admittedly. So if I was on the call a little bit sooner, I would have had some more, but yes. I think it always helps to get kind of involvement, at least, or participation.
Oh yeah, definitely. It was definitely fire. So yes, I definitely encourage them. They're so fun. And that was like one of those things where I was just like, yeah. And then, oh yes, I also want to thank you for those resources again. I don't remember if I thanked you last week, but I'm thanking you again because why not?
Oh, for sure. I hope they're helpful. They're pretty easy reads, I think. And when you kind of go through them, I think that are things that are easy to read because they're things that are applicable and that you may be interested in. So those always tend to be easier reads in general. But to answer the question in the chat, if they're good for residency application, I'm not entirely sure. I don't think it would hurt to say that you participated in virtual shadowing. I don't know. I think it depends on program to program whether they think that that's applicable or not. I think for most residency applications, they probably value more hands-on experience. But I think immersion into medicine in general is in dedication to the field is obviously things that they're interested in as well. Any other questions? Can you add it to your med school application? I think you absolutely can. Is it honored by every school like I indicated for residency? I'm not entirely sure. I don't personally sit on an admissions committee. I can, if you follow up with me, I would be happy to ask my own school if they honor something like this in order to get a perspective from an actual admissions committee. But I don't think it would hurt, especially if you have something to talk about. How you were immersed within medicine and it reaffirmed your interest in medicine. Those are all things that are important and that they want to see. So I think you can certainly add it. Will they think it's the best experience in the world? Maybe not. I think it depends individually on the school, on the program. So it may vary from school to school, but I don't think it hurts to add it at all. Especially in the midst of COVID, when a lot of things are, that was the whole kind of inspiration behind making this is, the fact that, you guys are often not able to get out in clinics because of COVID still. So that was the whole inspiration behind making this.